Hello everybody, I am Dr. Salil Pal, Senior Endocrinologist, Kolkata, Professor of Medicine, Department of Medicine, National Medical College, Kolkata. So we are going through a pandemic, that is COVID-19, and in this situation, diabetes came out to be the commonest comorbid condition. And managing diabetes in this situation, we often face much difficulties with much ups and downs in blood sugar. Today we'll discuss a patient of type 2 diabetes who had established cardiovascular disease. Mr. Sen came to me, a 53-year robust person with history of diabetes for last 6 months. He came to me for routine checkup and complained of only weakness and lethargy. He had family history of hypertension and ischemic heart disease like myocardial infarction. He was heavy smoker for last 30 years and left smoking for last 5 years and trying his best to follow a healthier lifestyle. He had history of acute MI 5 years back. His age is 92 years, height is 5 feet 8 inches, and BMI is in the range of obesity, that is 30.7 kg per meter square. Blood pressure is a little bit uncontrolled, 140 by 90 in the daytime and 160 by 100 in the evening time. He has hemoglobin A1C 8.4. LDL cholesterol is totally uncontrolled, 137 milligram per DL. HDL cholesterol is low, triglyceride is more or less within normal range, that is 156 milligram per DL. Renal function is like that, EGFR is 65 ml per minute and urinary albumin creatinine ratio is 50. On asking the drug history, he is taking metformin 1000 milligram twice daily, telmisartan and 40 milligram, atorvastatin 10 milligram daily, amlodipine 5 milligram, aspirin 75 milligram, and clopidogrel 75 milligram. In this patient, what should be our approach? First of all, basically you have to control diabetes. So we must have some glucocentric approach. Apart from this, see, this patient has already acute MI 5 years back. So our approach should be CV protection, renal protection, microvasculature protection, as well as weight reduction. And as the patient, in this patient is a busy person, so convenient dose schedule is also very important. Primary aim of this patient is cardio protection and optimum glycemic control. If we consider all the antidiabetic agents available, SGLT2 inhibitor and DP4 inhibitor combination in this patient is quite beneficial, as it will have cardio-renal protection, it will reduce body weight, simple regime, that is once daily, early and durable, achieving glycemic goal, that is hemoglobin A1C will be, reduction will be more than 1, weight loss will be there, and practically there will be no hypoglycemia if it is used only with metformin or only this combination is used. If we see the cause of death in diabetic subjects, cardiovascular disease is the leading cause of morbidity and mortality. And in fact, diabetic subjects suffer from ischemic heart disease or acute MI 2 to 4 times more in compared to non-diabetic subjects. And this cardiovascular disease is mainly due to atherosclerotic cardiovascular disease and diabetic heart failure. In this time, we have come across so many papers and studies that diabetic subjects suffer from heart failure much more frequently than non-diabetic subjects, which was not known earlier. But it is seen that diabetic subjects often presents with reduced ejection fraction or preserved ejection fraction. And in these subjects, prescribing SGLT2 inhibitor is very much beneficial. In the EMPA heart study, which was done to see the cardiac structure, function, circulating biomarkers in patients of type 2 diabetes, showed that empagliflozin resulted in early and significant reduction of left ventricular mass as detected by cardiac MR and imaging. And it reverses the cardiac remodeling and possible contributor to cardioprotective effect of SGLT2 inhibitors. In fact, 2015, that is after this study, EMPA outcome trial, which demonstrated significant benefit of empagliflozin for cardiovascular mortality by 38% cardiovascular events reduction in type 2 diabetics patients. All types of cardiovascular deaths were reduced with empagliflozin, but most prominent thing was that heart failure related deaths and sudden death were reduced much more than when compared to placebo or other treatment group. And like that, post hoc analysis of EMPA-REG demonstrated consistent cardiovascular mortality benefit. So cardiovascular risk factors should be reduced in a patient who already have acute MI and patients of long-standing smoking, obesity, undiagnosed heart failure or incipient heart failure is much more. So a combination containing empagliflozin will be much beneficial. And in the Carmelina and Carolina trials, when linagliptin was compared to the glimepiride, it was seen that linagliptin is as par with glimepiride in reducing blood glucose or achieving hemoglobin A1C in the Carolina. And in the Carmelina, when linagliptin was compared to placebo, it do not increases the incidence of heart failure, deteriorates the atherosclerotic cardiovascular disease. It is as potent and as equivalent with the other antidiabetic agents or placebo when cardiovascular outcome is considered. So, in this subject, if we choose Lina and EMPA combination, which is available as first-in-class treatment of SGLT2 inhibitor and DPP4 inhibitor combination, it is available as 25 by 10 or 10 by 10 composition, and it reduces hemoglobin A1C by more than 1% and documented hemoglobin A1C decrement by Empalina combination 25 by 5 is as high as 1.81%. And main thing is that this combination do not cause hypoglycemia, do not cause weight gain, it reduces body weight, it improves the cardiovascular outcome significantly, and linagliptin on and above reduces the microalbuminuria present in diabetic subjects to some extent. And SGLT inhibitor definitely reduces the microalbuminuria and kidney function. So in this subject, I think we should continue Empalina combination, that is 25 by 10, along with metformin 1000 milligram twice daily. After titration of antihypertensive should be done. Say for example, telmisartan may be increased to 80 milligram along with amlodipine 5 milligram. And as the patient already had acute MI, so he is a high risk person and statin dose to be increased and combination of aspirin and clopidogrel to be continued. My treatment may differ from your treatment, but considering this individual patient, I think this is the best treatment available for this type of patients. Thank you for listening.